Hi, I'm Dr. Randy Martin with the Marcus Heart Valve Center here at Piedmont, Atlanta, and I'm very honored and thrilled to have a visiting professor with us. Professor Patrizio Lancellotti is professor of cardiology at Liege in Belgium, and he's hot off of the airplane. He just literally flew in from Belgium, so we're thrilled. Patrizio is also the immediate past president of the European Association of CV Imaging and is chair-elect of the European Society of Cardiology's writing group on structural and valvular heart disease. So listen, thanks so much for doing this. You get off the airplane, you come right here, and we make you perform. But so you're visiting us, and you're going to give a very, very interesting talk today, tonight, when the title is called Aortic Stenosis: 50 Shades of Gray. I'm not sure. I'm not sure if this is X-rated or not. So, why don't you? We're honored to have you here, and thank you so much for doing this.
Thank you so much for the invitation. I will not take out any clothes.
You look good. You look good.
50 Shades of Gray.
Yeah, no clothes. No clothes. Don't take me into any rooms either. So let's go through and tell us a little bit about what this means.
Maybe just a few things,
okay.
Because we're going to focus on aortic stenosis and maybe the role of multimodality imaging in patients with AS. So,
okay.
After the movie came out, a lot of babies were born. And this means that a lot of cardiologists will be there and a lot of surgeons will be there. And to avoid, to speak like the Tower of Babel, we need to use a common language.
Okay.
And this is of importance. And even when you use, imaging and when you define aortic stenosis, you need to clearly identify what is exactly the definition of aortic stenosis. Maybe a little background.
That's great.
On the disease, the most common disease is maybe aortic stenosis in Europe, maybe mitral valve disease in US.
Right.
And the burden of aortic stenosis is steadily increasing as the population grows older.
That's correct.
So this is a very important topic to talk today. Maybe something very important, because we have defined this is a heart valve clinic, and we think that patients with valvular heart disease should be taken care in a very specialized and dedicated environment where specialists or healthcare professionals with expertise in heart valve clinic should work.
Right. And
this is just a general scheme of the heart valve clinic and the connection with the general cardiologist and primary care provider. We had the chance to write this paper and publish in European Journal about the rationale and about all the stuff in the heart valve clinics.
And it's critical that you have people, you have the cardiologists and the imaging cardiologists, probably the interventionalists, and maybe the surgeon and the nurse practitioners and all that. So excellent. So continue. That's great.
And here is just, the few things about the fact that the first imaging that you use in patients with AS is echo. And it's just to identify, the first thing that you have to look out when you use echo. For sure, you need to identify the type of etiology of aortic stenosis. And here you have the three common etiologies, but it was believed for long it was just degenerative in older people, but now we know that it's bicuspid as well. And you have to look at the number of raphe, at the fusion of the commissure, the calcification, so everything around to define perfectly the etiology of aortic stenosis.
Okay. Excellent.
This is of importance. Now regarding a bit of pathophysiology, this is very complex. I will not go through, into details, but just maybe because this disease shares common similarities with atherosclerosis and with skeletal bone formation, with lipid deposition, with inflammations, with a calcification process. And it has been shown something very interesting and maybe unique. If you use PET with some marker of calcification activity, you can predict the occurrence of calcification over time. And if you use MDCT or CT, you can perfectly depict calcification, the extent of calcification. So this means that with the assessment of the metabolic activity, mainly calcifications, you can identify patients who will develop more severe stenosis with a progression of the disease.
So it's a great point, because calcification of the valve on CT becomes extremely important as a marker of severe AS. I can't help but jump in. So a lot of the trials that said, okay, if this is a mimicker, it has cholesterol and all those things, would treating with a statin help to slow this down? The trials have not shown that. Is that correct?
No, not at all. This means that because the statin has mainly focused on lipid lowering and maybe, also on inflammation and not on the calcification process. Maybe we should try to have drugs working mainly on calcification rather than on lipid, except if we start earlier in the disease process, because lipid depositions will start like the initiation of the disease.
Okay, I could ask you some more about that, but let's go ahead because it's cool. No, it's very important. It's great.
So this is just a reminder regarding the pathophysiology of AS, but just because with the chronically increased afterload, that we have a lot of modification, LV remodeling, LV hypertrophy, change in myocardial function. We can have fibrosis, and at the end of the process, we can get over heart failure. So this means that it's a long disease. Ongoing, and recently it has been suggested something of interest. It is the disease staging from the American guidelines on that. I think there are a few important aspects in that disease staging that could be taken out, like we take care of the patients, the valve, the flow, and the ventricle. This means it is all related to the consequences finally of the aortic stenosis. And now maybe I will just highlight an important aspect. In aortic stenosis, management is dictated by two important things: symptoms and severity of disease. And maybe in some patients, if you have severe stenosis and you have asymptomatic LV dysfunction, this is also another parameter to take into account to refer the patients for surgery. But now I will show you this. Because what is important, why severity is related to symptoms? Because there is a clear relationship.
Right.
But here the tricky point is that even some patients with moderate AS can be symptomatic. And we don't know exactly what to do in these patients. And maybe in the future we need to have some trials on that.
It's a great point, because I think we wait, have historically, like in mitral gurge, have waited for people to develop symptoms. And while that's important, I think if I look at that moderate group who's sticking across the line there, their ventricle's being damaged, fibrosis is increasing, and so that's got to affect outcome even after successful intervention. So that's fabulous. Tell me a little bit more.
So this is again the disease staging coming from Nishimura and the guidelines, just to highlight exactly the definition. So stage A, B, C, D, we will not go through, but anyway, what is important, we can identify, stage C in asymptomatic severe AS and the stage D in symptomatic severe, and we can have different categories in each arm. This is of importance regarding, but if I have to redraw this, I will put this part up and this part down, because you can only decide which stage is the patient after having made the diagnosis. So you cannot start with the stage. So this is
it's a
little bit tricky.
It's the stages are a little debated among people. I understand.
So maybe this is a case. The movie doesn't work, but anyway,
that's okay.
Anyway, that's what is important. If you just have a look at the patients, it's a lady, 78 years, it's a male with history of calcific AS, hypertension, some risk factors, previous cabbage and neuro class 3. You can see hypertrophy.
There's some LVH, calcium on the valve.
Calcium on mitral. So it looks like severe AS.
EF 65%.
Yeah, but now if we look at what is recommended is at least to assess AS peak velocity, mean gradient, valve area using the standard continuity equations. And here what you have is a peak velocity less than 4, which means not severe AS if we just give more weight to AS velocity. Mean gradient 29, less than 40, but severe AS according to EVA. So what to do? This is a major discrepancy between guidelines.
We see this a lot. This is very common.
And this is tricky because it's very difficult to manage these patients, at least if they are symptomatic at a very high risk for surgery. Sometimes call some friends, they can give some clue, or you can also call other friends because, you know, CSI maybe is not Atlanta, but maybe it could be close to. So regarding classification of AS, if we take just the last group, the D group, we can say that it is related, you know, to gradient, to stroke volume, and also LV ejection fraction. And we can identify at least different groups. And again, here I'm back to this group because this is a new one that maybe we should take care in the future, are those with preserved LV ejection fraction but normal flow. We always talk about paradoxical low flow, low gradient, but we forget a bit this one, and we don't know exactly if these patients would benefit or not from aortic valve replacement. And maybe I will give you some clue afterwards.
So how do we tell? So how do we tell? That's no, I mean, that's good. You know, to the average, when I was in my early days in cardiology and we were in the early stages with CW Doppler, it was just, you know, if you had a high gradient, you had that. But things have changed, and I think this is really important. So let's let you continue.
So, and maybe the first thing when you have some discrepancy between, you know, the gradient and the valve area, you have first to check for flow conditions and LV functions. And there are a bunch, you know, of causes that can be related to reduced stroke volume, and you have to assess this very carefully. And also, the main reason for error in assessing AS is the measurement of alveoli diameter. And here you have all the recommendations, and you know we are working on the new recommendations, the update now on the assessment of aortic stenosis, just to try to put all these elements in, like the assessment maybe of the alveoli shape before, you know, measuring just this alveoli diameter using the parasternal long axis view, always with a zoom view. Of course, these are common, but if you do any error here, you will end up having a big error in assessing aortic valve area. So it's very important at least to say that the LVOT is clearly circular or not, but often is not.
Interesting, yeah.
Often is not. So maybe we should be very cautious when we use the continuity equation. Here is just to show you another example of mistake that could be performed, and it is here. If you measure, what it is recommended is to measure here. This is 1 centimeter below the aortic cusp. And what we do in my lab, we measure just this one. So we don't measure this one. Because here, if you have a very, you know, septal band or severe hypertrophy, you end up having mistake or error measurement. So we try not to fit with the guidelines.
And point out to the people that are watching us about these two, the top two diagrams, because that's very important, the difference in the red and the yellow arrow.
Yeah, if you measure here or if you measure here, it's not the same. So this means that with echo, we are not necessarily aligned perpendicular and really, you know, in the real good line to make the measurement. And also what is important is just to highlight again that this is almost circular, but in most of the case we have a minor and a really larger diameter. So we should be very cautious when interpreting this. And the advantage of CT or even with 3D echo, we can have the measurements of the sagittal diameter, which is common the parasternal long axis view, sagittal, or the coronal. We can measure this and we can see exactly the minor and the largest diameter. So maybe if you want to avoid measuring, you know, the alveoli, just take the 3D echo imaging and you can measure the stroke volume. And if you use this formula, you can have a calculation of the aortic valve area.
So stroke volume becomes very important.
I think with 3D echo, if you have a very good quality imaging, you could use really 3D echo to calculate the stroke volume.
But I don't mean to get you off topic, but in the patient you showed us, she had a big subaortic septal hypertrophy. I mean, it wasn't, but she's going to have by nature flow acceleration up under there. So measuring that stroke volume in that area is important.
Yeah, it's very important.
Okay.
Maybe just to highlight why is also important to measure stroke volume. of course, for assessing AS severity, but also because stroke volume already gives you some insight regarding the outcome. If you have a stroke volume, even in those with preserved the ejection fraction less than 43, you see, you have an increase in the number of events over the time. So this means that the assessment of stroke volume should be very careful in these patients. Here are some clues, to assess the severity of AS. The most important one is to take, multiple windows and to use the right parasternal views.
Correct.
Because this is of importance. And you see, we end up having the same mean pressure gradient.
Okay.
So anyway, this confirms that we have good measurements and probably we have very severe aortic stenosis. But maybe we need other things. Let me just highlight one important aspect, is the relationship between the valve area and the mean pressure gradient.
Correct.
We have a very good relationship, but in 1/3 of the patients we have a sort of discrepancy in the definition of severe AS. And if we use a valve area less than 1 and the mean pressure gradient, you see that 1/3 of the patients has less than 40, meaning no severe AS. But the valve area is less than 1, so severe AS. And this discrepancy could be related to many factors. Measurement errors, small body size, normal flow low gradient AS, inconsistency in guidelines, and also paradoxical low flow. This one that has been described perfectly by the group of Philippe Pibarot.
Right.
So now the question is, should we use, the body surface area to index valve area? And all the controversy around this. But if you have a suspicion of low flow, you need to do this.
So do that.
It's mandatory.
Okay.
It's mandatory. First thing to do, index for body surface area.
Okay.
Now, of course, if you have a severe stenosis, you should have some consequences. If not, it's impossible to have severe aortic stenosis. So for that, you can look at the ejection fraction. But in most of these cases, ejection fraction will be normal. But what you have to look is for mainly the remodeling process. And here is an example where you can use global strain, deformation imaging. And if you use the deformation imaging, is the shortening, of the left ventricle toward the apex and the lengthening when it is relaxing. And you can have an idea of the strain and the global function. And in this case, despite a normal ejection fraction, is completely decreased.
And this correlates in limited studies, but excellent studies with MR and gadolinium, right? So what you're detecting here, and I think you make a valid point, is EF is one marker, but it may be a late marker. You really would want to pick up fibrosis early. So global longitudinal strain is a great surrogate of that.
Yeah, and it can give you very interesting, information about the real intrinsic myocardial dysfunction. So probably ejection fraction clearly underestimates.
Good, excellent point.
This point, and this is the same patients, with the the patchy distribution of the fibrosis, not related like in ischemic disease,
Correct.
but really patchy. So it's a completely different pattern of fibrosis. And this was one of the studies we published a long time ago, showing this aspect that in the low flow, low gradient, you have a significant decrease in longitudinal strain, but also in radial strain, as compared to patients with high gradient. So maybe a part of the decrease, in flow, in low flow gradient, is also related to the decrease in radial strain.
So do you think we should, besides doing longitudinal strain, we should be doing radial strain in these patients too?
The problem of radial strain is mainly the
reproducibility.
We all know that, and that's a tricky point. But if it is accurate, it gives you
it's
some.
It's another data point. Okay, that's great.
And you see the correspondence here with the fibrosis and also the histology, because what is important is that the wall stress is increased at the basal part of the ventricle first. And after, of course, with the disease process, the mid part of ventricle will be touched, but the apex is almost preserved.
Excellent.
With CMR, I think CMR is interesting to assess fibrosis, You know, we have different types of fibrosis. Replacement fibrosis, and you can get information from late gadolinium enhancement here. But you have also with T1 mapping what is called interstitial fibrosis, or is a reactional fibrosis. Right. But we don't know now, because if we have to use it in patients, if this can give you clues regarding the outcome, if this can preclude patients to get some surgery like aortic valve replacement, because with the extracirculatory circulation, you can have ischemia. If you have ischemia reperfusion, you can end up, if you have severe fibrosis, with a patient with a low ejection fraction. We don't know. We still need more data on that. But I think it's the future to have more information.
I think this is going to be, I think this is very important. And again, the longitudinal strain is a surrogate, but this may have, there may be a lot more information in this, so that's great. So, okay?
So this was one study that we published in JACC showing, the difference according to different categories of aortic stenosis. And we defined this according to flow and gradient: normal flow, low gradient; normal flow, high gradient; low flow, high gradient; and low flow, low gradient.
So is there? I mean, I'm looking at the absolute values. So is there a difference? In other words, if you saw, like on the patient you just showed me, you showed minus 12% or something like that. So that tells you unequivocally that you have some fibrosis or something going on with the ventricle, right?
And at least in those with low flow, low gradient. So meaning that these patients are more sick or sicker than the other one. And this was another study that it was a multicentric study with our colleagues from France that we published in Cardiovascular Imaging, showing that it's mainly the base of the left ventricle that is touched in these patients with low flow.
That's interesting.
So, now the next steps would be to evaluate the associated findings. And what is exactly associated findings? Is calcification.
Absolutely.
And with CT, this is the patients that we had, and you see high calcium score. And if we look at the literature, there is something very interesting, because maybe the pathophysiology of AS in women and men is absolutely different, with more fibrosis in women and more calcification in men, because the cutoff associated with severe AS is clearly different in women and in men, less in women and higher in men. But in some studies, what was of interest was this point. So half of patients with low gradient and increase in AVC load. So meaning that with NSCT, you can measure calcium score or the calcium load, and you can estimate the severity of AS.
Yeah, I mean, I'm becoming more and more convinced that the amount of calcification you've got in the valve is clearly a great marker that you've probably got significant AS.
I think so. I think we should use this in those with discrepant value.
Absolutely, absolutely. That's great data.
And this is maybe a small study coming from the group of Philippe Pibaro, this one, and this is the case that we had, showing that with the butamine you can have a significant increase in mean pressure gradient. But I would be very cautious by using dobutamine stress echo in patients with low flow, low gradient, because the ventricle is so remodeled that you can get, some LV obstruction with decreasing blood pressure. Correct. It could be dangerous. But so very cautious.
Low dose.
Low dose. Really low dose.
Really low dose.
Really low dose. This is,
So Philippe's.
Yeah, the role of the butamine in AS I will not go through, but what is important, because the butamine gives you, first thing, to distinguish true severe AS from pseudo-severe, and give you also insights regarding the operative mortality. Here is the tricky part, are those, I would say, with indeterminate AS severity, where MSCT could be of...
Could play a role,
yeah,
absolutely.
A good role, I would say. So now let me just highlight a few things regarding the follow-up of these patients. For sure, we have a very wide individual outcome and clinical progression and hemodynamic progression of aortic stenosis. So this means that individual risk stratification is mandatory. This is the first thing to say. And if you have to follow the patients, maybe it should be followed in a dedicated environment, like a heart valve clinic, like what you have here.
Absolutely.
So these are all the things that people knows exactly how to repeat.
You're going to take me through some of this? I mean, because I'm really curious, as we were chatting before, about exercise testing. When do we do exercise testing, and what are we looking for in that?
Maybe I will come a bit later with exercise.
That's fine.
Because, you know, I think exercise is part of the risk stratification of asymptomatic patients with severe aortic stenosis. This was it is just a paper that we have submitted, and we just try to identify what would be the role of imaging in the clinical...
With the various stages.
Yeah, with the various stages suggested by, you know, the American guidelines. Now, another aspect, very important, is the outcome related to the use of imaging.
Okay.
And here you can see that this is the patients with asymptomatic severe AS. And you have all the data related to imaging that are associated with a poor outcome. Just as an example, the calcification, LV hypertrophy, the mid-wall fibrosis, the decrease in longitudinal functions, the absence of contractile reserve on exercise echo. You can also have the pulmonary hypertension during exercise test, the increase in mean pressure gradient during the exercise test. You have also the high peak velocity at rest and the high global afterload. So these are all the data that you can just take out from imaging to identify and stratify the risk.
That's a great slide. I mean, everybody ought to memorize that because
I hope
because what you're doing is that you're showing all the sort of data that would substantiate a diagnosis. Okay, so that's fabulous.
And we did the same with those with reduced LV ejection fraction and severe aortic stenosis. For sure, there you see we need more. We need more.
But in these people, I don't mean, there are two things that I look for: the degree of calcification and BNP. Is that right in these people who look like they've got a bad ventricle and you're wondering whether it's the valve or the ventricle?
At least these are the data that we have. So if you have a very high BNP and severe calcifications, the outcome is impaired. But I think it would be great to have some fibrosis information and even maybe other biomarkers.
But is that, and I think you're exactly right, but that's really for prognosis, isn't it? I mean, in other words, you're trying to determine, is this the valve? We know that the outcome in this patient's not going to be as good, but if you have a lot of fibrosis, it would not be as good as if you didn't have that, but if you have a lot of fibrosis, you're going to have even a worse outcome with good surgery.
And maybe,
or a good TAVR.
Yeah, and maybe you can orient it toward TAVR rather than that.
That's what I was thinking. That's great. Beautiful slide.
So this is just the definition of the paradoxical low flow. So you have always to take the picture of the patients of the left ventricle, the aortic valve. And if you have everything, this fits clearly with paradoxical low flow.
Let me ask you, in the valvular arterial impedance, that's do you routinely try to do it in these people? Do you think it's and I know Philippe does. Do you think it's of great value?
But
it's a difficult measurement.
I know it's difficult, but now it's like automatic on our echo machine.
Good. Okay,
we
that's
just
what I'm
need
asking.
the blood pressure.
Okay, that's great.
Good
point.
That's interesting. And you have already some measurements. For sure, it could be affected by the level of blood pressure.
Sure.
This means that the first thing is to measure the blood pressure, and if the blood pressure is high, you need to control first the blood pressure.
Correct.
Before making any diagnosis, for sure.
Cool. Okay, that's great.
So now this is the imaging, but associated with the clinical outcome. And this was one of the papers we published, where we can see that when you define exactly the group fitting with the severity of aortic stenosis, you can define the outcome, and those with low flow, low gradient were those at really higher risk of developing events during follow-up. Now, these are different. This is a meta-analysis from Philippe Pibarot, very interesting again, showing that if you have a low flow, the outcome is impaired.
Correct.
But here you can see that those with normal flow are getting maybe worse as compared to those with high gradient. So Now, what are now treatment decisions guidelines according to imaging? For sure, in guidelines, it is advocated to wait for symptoms before referring patients for surgery, and we have to balance, the risk and benefit of any intervention. Sometimes the watchful waiting strategy is difficult because we need to recognize, so this means we need to educate the patients. This is the role of the heart valve clinic.
Absolutely.
So they should mention promptly the symptoms occurrence and so on. So sometimes it's difficult depending the environment. But for sure, there is no randomized study. So we don't know what to do.
Okay.
And we just follow the guidelines. This is the reason why we try to understand exactly if the guidelines are right or not. And we set up what is called the Heart Valve Clinic, international database, where it's a group of volunteers with Heart Valve Clinic, and they put together all the data collected after the guidelines published in 2006.
Okay.
And so now we are, getting results, and we will be able to publish many things during the next coming months. And this is just a review paper that we just published in JACC Imaging concerning the role of valve stress echocardiography in patients with valvular heart disease. And this comes from the HEVIC group, and your hospital.
Good.
Very pleased to be in. And
that's great.
It's a real honor.
That's great.
So now coming back to guidelines, maybe we will not go through all the slides because there are so many, but just to highlight a few things regarding the management, you see that we can now fit exactly the disease staging according to the diagnosis. You should first make the diagnosis and after decide the treatment. Okay. So this means you can define the stage. Here is just the example of patients with severe aortic stenosis. If you have a decrease in ejection fraction, this is a class 1.
Even if they're, quotes, asymptomatic. That's a class 1, unequivocally. Okay.
And till now, there were no studies on that, but we have got just one publication from the Mayo Clinic showing that this is, of course, very important. And in the others, you need to stratify the risk.
Okay.
And there, the exercise echo plays a major role.
So let me ask you, I'm sorry, I'm not jumping ahead. We all agree that if you've got the high risk, the very high velocity across the valve, 5.5, good LV function, and if they're low surgical risk, that's a 2A classification. But aren't they really, aren't you going to try to be a little bit more aggressive in those people? I mean, in clinical practice?
I think if the patient is young and they want to practice some, exercise, sports and so on, you should intervene. Okay. Yeah, pretty sure. And even in elderly people, because the rate of progression is higher.
Pretty rapid.
Yeah.
I mean, you look at those. Let me ask you.
But we need more data because we don't have enough.
We really don't.
And maybe the AVIC will provide us.
I hope it will. Exercise testing. So historically, we've looked at development of symptoms, fall in blood pressure. You have in here mean gradient, and I know you've published a lot on that. How reliable is mean gradient? If you have a mean gradient over 20, goes up more than 20, is that a reliable sign that that's probably significant AS?
Yeah, the interpretation should be cautious because you should not just interpret the increase in the pressure gradient. The increase is a bad sign because there is a limited valve compliance. Correct. Or maybe because the valve stenosis is very severe, even under resting conditions. But if you put this plus pulmonary hypertension during exercise, and plus no contractile reserve, the patient is at very Excellent. High risk. Excellent. And there you should intervene. For me, if you have this kind of patient, it's not a class 2B, it's a class 1.
Right. No, that's what I'm thinking. So, but that's a great point because what you just mentioned to me is you're putting together multiple factors, not just one number.
No, because the one number just came out, in the European guidelines, and we just take this number. But I think it's a complete interpretations with multiple parameters and not just, one single magic number.
Good.
So these are always the same, with the same aspect regarding, the symptoms related to AS, the stratification according to the severity, the left ventricular ejection fraction, and you can use the butamine to evaluate if the stenosis is severe or not.
Right.
But what is important, if you don't have any And this is a mistake to call this contractile reserve. This is a flow reserve. This was
Correct.
called contractile reserve,
Correct.
but it's a flow reserve. If you don't have any flow reserve, and you look here, you manage these patients medically or with aortic valve replacements, you have an increase in the mortality rate related to the intervention, but if you survive, the outcome is better. So this means that you cannot preclude interventions just due to the absence of flow reserve.
Correct. I mean, it denotes a population who's, at not going to come back to normal baseline, but it's not somebody that you shouldn't intervene on. That's really what you're saying.
And there, the role of TAVR, it's wonderful.
Very
and maybe it's a door
Maybe.
that
That's
is
exactly
open.
right. Exactly.
So here, if you are in the stage D with symptoms and you have the D2, this low flow, low ejection
Right.
fraction,
Right.
okay, dobutamine, but in those with preserved ejection fraction, maybe you should use this to decide if you have to intervene with AVAR, like surgical, or with TAVR. Because if you have severe fibrosis, maybe it would be risky to perform
so
surgery.
you're giving us some really good insights. So what you're saying is that we've got to, while we historically have relied on Doppler and echo imaging, that being able to put together sort of pathophysiology thinking and looking at ventricular, so how bad has the ventricle been damaged is really important. So calcium, BNPs, fibrosis, and not only does that help you with diagnosis, but it says, should this person go to surgical or TAVR?
And
It's a great, we don't have, this isn't, are you saying that we're getting to the point where, especially in your practice, where you feel like this is really driving you in making those decisions?
Yeah, we use all this when we want to take the decisions. And even in those where the risk is limited to have an indication of TAVR versus surgery, we try to have all this information before deciding.
Is it your feeling that if you're on the side where you've got high calcium, high BNP, extensive fibrosis, bad global longitudinal strain, that the TAVR might be a better choice because it's less of an insult on the heart than surgical? David Adams' good friend says a day on the pump is a big day in your life, and it is. So it might be less of an insult.
And also less probably, patient's prosthesis mismatch.
Correct.
With TAVR.
Correct.
And that's important in very bad ventricle.
That's excellent point. So this you're gonna wrap up here because I know you've got you've done. Okay, so go ahead and show me what you've got here because this is cool.
Maybe just to finish with one important thing, this one related to the impact of aortic valve replacement in these different subcategories. Just to show you what I said before, you see here these patients with normal flow but low gradient, and if you look the impact of AVAR, it's very important as compared to conservative treatment. So I think that maybe in the future, and I will go through now just to show you maybe the hand, in the future we should define a D4 category.
Interesting point.
Because maybe these patients can also benefit from aortic valve replacement.
Interesting point.
So this could be very complex. You see what I said? It's not practical.
Doctor, where am I on this curve?
I don't know. It's impossible to use in daily practice, but it's very interesting for a pathophysiological point of view. And now, if I have to conclude these presentations with the title, I would say, ladies, come on.
That's a fabulous thing. But you know what's neat about this is that you've taken symptoms and then findings and tied it to guideline-directed management. So aortic stenosis does have 50 shades of gray, and it's gotten much more complicated. But you're pointing out the role that being a clinician and using multiple modalities of imaging and some blood testing is probably the way to not only diagnose the patient but stratify their risk. Is that correct?
It's correct. And I think in the future maybe some new biomarkers can come out and they can be used in daily practice.
Is this, do you get the feeling that I know your colleagues in Europe have been well ahead of us in doing a lot of this, and I think it's really good. Are you getting the feeling that this is becoming reproducible across multiple hospitals, multiple labs, so that people are beginning, because this data, when you start, like we talked about stroke volume and all that, I mean, the reproducibility is the big issue.
Yeah, but with imaging, reproducibility is a nightmare sometimes. This is the reason why we have now to try to standardize everything. So we should maybe try to also discuss with industries to standardize at least the way that we can assess the strain for sure, but also the calcium score,
right.
also the fibrosis. There are many things there, but maybe working with them.
Well, I mean, you make some great points, and so oftentimes people think, well, what's the gradient? Is the valve calcified or not? But you've really pointed out the importance of that disease on the ventricular function and then the outcome and the prognosis. Listen, Patrizio, you've done an admirable, you get an Academy Award for this performance because you come after 9.5 hours on an airplane and come in here and do this. But it's fabulous stuff, and you've really taught us a lot, and we deeply appreciate you coming.
Thank you so
very
much.
Thank you. I hope that you've learned as much as I have. Thanks for joining us.
Bye-bye.